Hello everyone. Today's lecture is based on local anesthesia in dermatology. Now, there's hardly any procedure in dermatology that we do in which we do not require local anesthesia. Might be in the injectable form, might be in the topical form, but local anesthesia is a must know in dermatology, particularly if you are interested in doing procedures. Okay. But before I move on to local anesthesia and dermatology, I would like to inform you that you can visit www.dermacoaching.org to know about the various lectures that we have taken in detail in dermatology. And also, you can write an email to me on this particular email ID, which is DERM, that is Derm Niharika, NIHARIKAJHA, that is Derm Niharika Jha at gmail.com. Coming back to local anesthesia in dermatology. What does local anesthesia do? It basically abolishes the pain sensation without compromising on the consciousness of the patient in a localized area. That means when we are operating on a localized area, that particular area will get anesthetized. The patient will not feel pain in that particular area, will allow us to operate without much hindrance, and it will not also compromise the consciousness of the patient. How is this effect achieved? This effect is achieved because local anesthesia diffuses across the nerve and it binds to the intracellular receptor. There are various types of anesthesia, but basically we divided it into two major groups. One is the extra group and the second one is the amide group. In the extra group, local anesthesia such as procaine, tetracaine, chloroprocaine, and amide group includes lignocaine, prilocaine, and bupivacaine. So these are the common anesthesias which are used by various practicing dermatologists and other doctors as well. Out of all these anesthesias, lignocaine is the one that is used most commonly by the doctors as a local anesthesia. Lignocaine is present as or available as plain lignocaine and lignocaine in combination with adrenaline. So that is how I will be addressing it, plain lignocaine and lignocaine with adrenaline. So first we will be talking about the plain lignocaine. It is the most common anesthesia, local anesthesia, which is used by the doctors. The maximum dose of plain lignocaine in adults is 7 milligram per kg. When it is used in combination with adrenaline, then a dose of 4.5 milligram per kg in one session is the maximum upper limit of lignocaine with adrenaline in adults. If we are dealing with children, half this dose is the ideal upper limit which can be given in the children. If we talk about the volume, 20 ml of 1% lignocaine or 50 ml of 1% lignocaine with adrenaline can be used. This is the maximum amount that I am talking about. But if we're operating on a large area and large quantity of lignocaine is required, it is better to use a diluted version, which is around 0.5% of the concentration of lignocaine. Now let us talk about lignocaine with adrenaline. This is plain lignocaine. This is how it looks like. And now we are moving on to lignocaine with adrenaline. So what is adrenaline? Adrenaline, it is a vasoconstrictor. It constricts the blood vessel. Okay. What are the benefits? Because it is constricting the blood vessel, there is decreased absorption of the anesthesia, and hence the systemic toxicity that can be produced by the lignocaine is reduced. Because of the vasoconstricted action, there is less bleeding at the operation site and there is prolonged duration of action of the anesthesia. The concentration of adrenaline that we use is 1 in 1 lakh units. But it is associated with certain contraindications. Few of them are absolute contraindications and some of them are related contraindications. Absolute contraindications include severe hypertension, those patients who are having severe hypertension or cardiac diseases, or pheochromocytoma, or those patients who are having severe peripheral vascular diseases. There are certain related contraindications as well, out of which most important is the site. So we should avoid using lignocaine with adrenaline in places such as distal extremities, the fingertips, the toe tips, the nose tip, the ears, penile area, because these areas ischemic necrosis can happen. Okay, because they are having end arterial blood supply, and because of the constricting activity or action of the adrenaline, ischemic necrosis can happen. So it is better to avoid lignocaine with adrenaline at these sites. Apart from that, it should be avoided in pregnancy. In first trimester, it can interfere with organogenesis of the fetus, and in the third trimester, it can precipitate labor. It can also precipitate psychological instability or psychosis in patients who are, having psychological instability problems beforehand itself. It is better to avoid lignocaine and with adrenaline in patients who are on beta blocker therapy. So these are the relative contraindications. The absolute contraindications include severe hypertension, cardiac diseases, and peripheral vascular disorders. This is how a combination of lidocaine and adrenaline looks like. But is local anesthesia available only in injectable form? No, it is also available in the topical form. By topical, I do not mean only the cream form which are available. It is also available in jelly form, for example, lidocaine. It is also available in the aerosol form. So topical anesthesia, it produces a superficial anesthesia up till the papillary dermis, and it is even more effective on the mucosal areas, because from the mucosal areas, the absorption of the topical anesthesia is considered to be equivalent to that of giving an IV injection. But the mucosal surfaces can, on mucosal surfaces, not every kind of topical anesthesia can be used. For example, the cream form, which is used on the intact skin, in fact, it has a warning on it that it is not supposed to be used in the mucosal area. So, what kind of topical anesthesias are used in the mucosal area? So, lidocaine 2.5 jelly. This jelly is particularly used in those patients who are having oral erosions and oral ulcers, and if applied half an hour before the meals and then washed off, then the patient will be able to keep the meal peacefully, or else the patient will be having pain. So, in such cases, jelly can be used. Then it is also available in aerosol form, might be the spray and the pump form. So this aerosol form is particularly used by the dentist and ENT surgeons, so that they can directly spray it over the mucosa and operate on that area. But for topical skin, for topical application on an intact skin, a combination of lignocaine and prilocaine is used. Where lignocaine is 25% and prilocaine is 2.5%. It has to be applied 1 to 2 hours prior to the operation, so that a proper anesthetic effect is achieved by the time we start operating on it. So this particular EMLA or Prilox or Toplac or Numpex cream, which is topically available in India, this kind of topical cream-like topical anesthesia should not be used on mucosal surfaces. For mucosal surfaces, jelly or aerosol forms are available. In dermatology, we use topical cream anesthesia for doing procedures such as media removal, molluscum removal, wart removal, mole removal, for doing, vitiligo surgeries, skin grafting, and shape biopsy. So it is very important in dermatology. I would tell you one another indication. It is not related to dermatosurgery as such, but when females, whenever we are going to the parties and we want to wear long, heavy earrings, we can pre-apply, Prilox cream and then wear the heavy earrings. In that case, it won't hurt. So I also do that. Okay, so lidocaine, this is and Prilox combination, lidocaine and prilocaine combination available as Prilox. Infiltration anesthesia. What is infiltration anesthesia? So basically, infiltration means we are infiltrating the area with local anesthesia where we need to operate. This is the most common kind or the type of injecting technique that we use. It can be given in an intradermal form or as subcutaneous form. So anesthesia is placed near the nerve endings by giving an intradermal or subacute injection. Whenever we give intradermal injection, it results in a little wheel-like formation and blanching of the overlying skin. Whenever we are giving the subacute injection, always aspirate, because if by chance we have entered the vessel and we inject the anesthesia, then the chances of systemic toxicity increases many folds. For a functional onset of action, it is better to massage the area where we are injecting. Okay? This diagram shows that what are the various techniques by which anesthesia can be given. We do not go for intramuscular injection. We usually go for subacute and intradermal injection while giving infiltration anesthesia. And these are the other two injection techniques. Okay, intramuscular, in dermatology, we use for giving tripod injections while treating nail psoriasis, nail LP, that can be given, and it is given perpendicularly. Subacute injections are given at an angle of 45 degrees. Intravenous, we have to directly target the vein. Okay. And intradermal, it is given at an acute angle of 10 to 15 degrees. So you can see it's almost like lying flat to the skin. Whenever we give an intradermal injection, a small wheel is raised and the overlying skin becomes blanched out, and it also there's a wheel-like formation. Again, this shows the formation of the bleb when we give an intradermal injection. What is tumescent local anesthesia? So, tumescent local anesthesia, the name signifies that this anesthesia is given to tumefy the area. What do you mean by tumefy the area? That means when we inject this anesthesia, there is ballooning of the area where we need to operate on, or there is distension of the area where we need to operate on. Here, a large amount of diluted lidocaine, it is injected subcutaneously to balloon out the area or to tumefy the area. What does it consist of? It consists of 1000 ml of normal saline, 50 ml of 1% lidocaine, 1 ml of 1 in 1000 adrenaline, and 12.5% of sodium bicarb. Hence, the effective concentration of lidocaine which is produced is 0.05%, and the upper safe limit for the same is 35 milligram per kg. Tumescent anesthesia is also placed in the subacute area where the free nerve endings are few and lax tissue is available, so that the lax tissue gets easily distensible. So, what is the advantage of tumescent local anesthesia? Because of the ballooning effect or the distension effect, there's a stretch of the skin which is hence produced, and it provides us a good working area. So even the lesions will become more prominent, and we are able to approach the lesion more confidently. Then, because of the ballooning or the cushioning effect, there is protection which is provided to the underlying structure, deeper structures, which can be harmed otherwise while doing the procedure or the surgery. So it not only provides a distended area for us to work on, it also prevents the damage to the underlying skin. Okay. Then small amounts are required to anesthetize the larger area, hence less amount of anesthesia is required. But the onset of action takes around 10 to 15 minutes, and after 15 minutes of time, this anesthesia effect can be seen. Tumescent anesthesia can be used for doing procedures such as dermabrasion, skin grafting, hair transplantation, rhinophyma corrections, and other surgeries. Then there is field block or the ring block. As the name suggests, it provides a field of anesthesia or a ring of anesthetic area where we are going to operate. So anesthesia is seen in the entire operative field by injected in the peripheral area, both intradermal fashion or subacute fashion, but in a circumferential fashion. This is the type of infiltration anesthesia only. Okay? This kind of anesthesia where we are giving a ring anesthesia or a field block, and we are anesthetizing the entire operative field using a small amount of anesthesia, is used for doing biopsies, for removing benign skin tumors, for doing cyst excisions, particularly epidermal excision of a lipoma removal. All these surgeries can be done under field blocks. Then for doing nail surgeries as well, field block is used. Kind of similar anesthetizing, giving kind of similar anesthesia technique is the peripheral nerve block. In the peripheral nerve block, the nerve trunk is the target rather than the terminal nerve endings. And here, uh, you know, uh, basically what is happening, we are giving the anesthesia at the periphery rather than the site itself, and we are not targeting the terminal nerves. This kind of technique is used when we are operating on the nails for doing nail surgery, or for example, on a finger, single finger, multiple warts are present, so we can, give a peripheral nerve block and operate on the whole of the digit, or we can give a nerve block on the face and do PRP without any pain. Then penile block can be doing for removing a lesion from the penile area, for example, large condylar matter, some benign tumors, etc. Okay. What is the advantage of peripheral nerve block? Advantages include that there is reduced discomfort to the patient and large areas can be covered in small doses. And obviously, because large areas are being covered in small doses, so the risk of systemic toxicity is also reduced. Disadvantages include lower onset of action. It takes around 3 to 10 minutes for the onset of action after giving the anesthesia. Now, before going on to the side effects of the local anesthesia, I would like to show you a small video so that you are able to understand what is distal digital nerve block. So, distal digital nerve block, this is the technique of giving a distal digital nerve block. So we have to operate on the nail. I have to do a partial toenail avulsion, but I'm not injecting near the toenail. I'm giving a distal digital nerve block. So the whole toe gets anesthetized and I'm able to operate on the toenail with comfort, and the patient is also not under distress. Now I would like to proceed with this video for a little more while, because while operating, while giving anesthesia to this patient, and I was trying to withdraw before injecting, and when I withdrew, there was blood in the syringe. This shows what is the importance of aspirating before we inject. Because if by chance you are in the vessel and you inject the anesthesia, the chances of systemic toxicity increases multiple folds. You can easily see that there is blood inside the syringe. So I had to take another syringe and then re-inject it. Again, before injecting it, I withdrew the plunger, and then after aspiration, I pushed the anesthesia inside. So this always aspirate before injecting so that you are sure that you are not inside the vessel. Okay. Moving further to the side effects. Side effects can be local or it can be systemic, and side effects can be caused by the local anesthesia as well as adrenaline. So local side effects by anesthesia include pain, ecchymosis, secondary infection. Adrenaline can result in tissue necrosis or delayed post-op bleeding. Well, the systemic side effects of the local anesthesia are multiple. So, cardiac side effects of the local anesthesia include hypotension, bradycardia, ventricular arrhythmia. Then, respiratory side effects include respiratory depression or respiratory arrest. Other side effects include circumoral numbness, there can be tingling sensation, lightheadedness, there can be hallucination, diplopia, sometimes even convulsions can get precipitated. And obviously, anaphylaxis and vasovagal reaction is associated with whatever drug we are giving. That cannot be avoided. But obviously, if anaphylaxis can be avoided to some extent if we given intradermal text prior to injecting the local anesthesia. As far as adrenaline is concerned, systemic side effects to adrenaline include transient tachycardia. It can aggravate chest pain, precipitate angina, can cause cardiac arrhythmias, can also cause headache, nervousness, and tremors. But are there any ways by which all these side effects, systemic reaction, can be avoided? Yes. First of all, we should use the minimal amount of local anesthesia which is required to operate on a particular area. As far as possible, use lidocaine and adrenaline combination if adrenaline is not contraindicated, because adrenaline being the vasoconstrictor will prevent the absorption of the local anesthesia into the system, and hence the systemic toxicity can be avoided. We need to take a proper drug history. We should ask the patient before injecting the anesthesia if he or she has been exposed to local anesthesia prior to this procedure. If yes, you can continue with the procedure. If no, or if the patient cannot recall, do give a test dose prior to injecting the anesthesia. If the test dose is fine, then you can definitely proceed with the procedure. We need to take a proper drug history if the patient is on aspirin, beta blockers, or anticoagulants. If you're operating on a larger area, use brain blocks, field blocks, or peripheral anesthesia or tumescent anesthesia. This way, the patient will also be more comfortable for the procedure. Whenever you are injecting, before injecting the anesthesia, always aspirate. I just showed you that while aspiration, blood came into the syringe. So it does not matter if you are experienced or you are not experienced. A few seconds will not prolong your surgery by a lot of time. It will, on the other hand, save you. It might save you from some mishappening. Defer any elective surgery in pregnant or lactating females because of the fear of any systemic toxicity that can develop in the fetus. So this is all about local anesthesia and dermatology. I hope you liked the lecture today.